A 40-year-old man is brought to the emergency department by paramedics. He developed palpitations whilst at the gym. He has no significant past medical history. On examination, he has a heart rate of 170 beats per minute, BP 123/65 and RR 20 breaths per minute. At no point did he lose consciousness, become breathless or complain of chest pain. Which of the following treatments is most appropriate for this patient? A. Synchronized DC cardioversion. B. Amiodarone 300 mg IV. C. Metoprolol 5 mg IV. D. Adenosine 6 mg IV. E. Verapamil 5 mg IV. The answer is B. Amiodarone 300 mg IV. The ECG and history are consistent with ventricular tachycardia. The patient has no adverse features, and therefore IV amiodarone is indicated. Treat with amiodarone 300 mg IV over 10 to 60 mins, followed by an infusion of 900 mg over 24h. A 73-year-old woman is brought to the emergency department by her family. She complains of dizziness that started 2 hours ago. On examination, she is found to be bradycardic with a heart rate of 42 beats per minute. She is normotensive and has no history of chest pain or breathlessness. Her ECG shows a ventricular rate of 44 beats per minute, with a narrow QRS, fixed PR interval and intermittently non-conducted P waves. What is the recommended treatment for this patient? Options are A. Observe. B. Atropine 500 micrograms. C. Amiodarone 300 mg. D. Transcutaneous pacing. E. Adrenaline 100 micrograms. The answer is B. Atropine 500 micrograms. The patient is bradycardic without adverse features. This would not normally require immediate treatment, however the ECG shows a Mobitz type 2 AV block. There is an increased risk of asystole with this block and therefore treatment is recommended. In a patient with no adverse features but with a high risk of progression to asystole, treat as for patients with adverse features. A 54-year-old man presents to the emergency department complaining of a 1-hour history of central, crushing chest pain. He is diaphoretic and ashen. A 12-lead ECG shows ST elevation in leads 2, 3 and AVF. There is reciprocal depression seen in lead 1. Which coronary artery is most likely occluded? Options are A. Left coronary artery. B. A right coronary artery. C. Left circumflex artery. D. Proximal left anterior descending artery. E. Distal left anterior descending artery. The answer is B. Right coronary artery. ST elevation in leads 2, 3 and AVF, with reciprocal depression in 1 suggests an inferior MI. This is most commonly caused by right coronary artery occlusion. A 64-year-old woman presents with a 3-day history of palpitations. She has experienced similar episodes for the last 2 months. Her observations recorded at triage are: heart rate 105 beats per minute, blood pressure 165/77 mmHg, respiratory rate 18 breaths per minute. You note her pulse is irregularly irregular. She has a past medical history of type 1 diabetes and hypertension and is prescribed insulin and ramipril. Her CHAD2DS2 VASC score is 3. What is the usual threshold score for treatment with anticoagulation in a patient with atrial fibrillation? Options are A1, B2, C3, D4, E5. Answer is B2. Assess the person's stroke risk using the CHA2DS2 VASC assessment tool. Anticoagulant treatment is generally indicated by CHAD2DS2 VASC scores of 2 or more, and treatment should also be considered for males with a score of 1 or more, taking bleeding risk into account. Where anticoagulation is being considered, use the HASB LED assessment tool to assess the risk of a major bleed and to facilitate the identification and management of modifiable risk factors for bleeding, such as uncontrolled hypertension, harmful alcohol consumption, and concurrent use of aspirin or a non-steroidal anti-inflammatory drug. Anticoagulation can be achieved with the drugs Apixaban, Dabigat Ran Etexylate, Rivaroxaban, or a vitamin K antagonist depending on the person's clinical features and preferences.